So literally everything I've learned about this, I learned from teachers, because teachers are doing this work, and I'm just trying to figure out how to support them. And so what I'm going to talk about today is sort of thinking about social emotional learning as a public health problem. So when I started being interested in social emotional learning, it was around 1980, and I was trained as a clinical psychologist, and I realized that treating one child at a time would never reduce the rate of child mental health problems, and that we had to think differently. And it was just when prevention was beginning, it wasn't even called a field yet. And people said to me things like, well, it's just kids' personalities. Some kids are difficult and some are not, and the idea that you're actually going to teach them how to become more socially skilled, to get along better with others, to think ahead about their problems, to solve social and interpersonal problems, was just, it didn't make sense, because this is just personality. And at that point, we really had to do basic trials just to show that when you did social emotional learning and you did it well, you implemented effectively, children improved in all these areas. And now that's well shown, and you know about probably the meta-analysis have been done showing these effects in 217 studies. But now the question is really, okay, so we know that social emotional learning works when it's done well. What are we going to do with it? How do we make it part of our standard system of education and well-being, physical health, public health? So that's sort of the thinking. How do we take a broad public health approach to SEL? And what does it mean to be systemic? What is its relevance to education? Okay. How many of you are teachers here in the room? Good. Okay. So the roadmap, I'm going to talk a little bit about universal interventions and what their value is. Why should we be doing this universally? Why not just pick the kids that are already having problems in the classroom and give them special help from a counselor, school psychologist, social worker, et cetera? And because why should we be wasting the time of all the other kids in the classroom that don't need this stuff? Okay, this is what I used to hear. So what is the value of these interventions? And in the first part of the talk, I'm going to talk about the value. In the second part of the talk, I'm going to talk about some of these analytic issues that it's partly how we see the data. The data is already there, but we can look at it different ways and can tell us very different things. And then I'll talk a little bit more about the need for longitudinal data and how to more deeply understand what our findings are in the second part. Okay, so why focus on universal interventions and maybe selective interventions? So the past decade, we've seen a convergence of research in education and prevention science. Before, there was none. And, but there's not that much integration. Like Kim's an unusual person now and helps in a school of public health, population health. But people in education and people in population health and people in psychology and child psychiatry, they have no communication for the most part. They use completely different ways of thinking. They use different methods for studying. They use different models of analysis. It's really problematic. And so what I'm calling for is an integration where public health methods begin to get used in education. And there are lots of questions here about this. How can we better understand how universal interventions impact different segments of the population? So for example, in public health, if we want to do an intervention to reduce cholesterol for everyone in the population, we're going to look at people that start with different bands of cholesterol levels and see what levels are mostly influenced. We're not that concerned about influencing people that have cholesterol below 70. We're sort of interested in people that have cholesterol over 150. And we're really concerned about people that have cholesterol over 200, right? So we want to understand where our interventions are working. And we have done very little of that in education and psychology. And then why do certain effects fade and why do they reemerge? This is a big problem for us, because I've had a bunch of experiences I'll talk about in which that's the case. So this is what's called the Institute of Medicine spectrum. Do you all know this? So this is the sort of the spectrum of prevention and treatment. And mostly what I'm talking about here is universals. That is for something for everybody. So the other day I was on the phone with public health people and they said, well, wait a second, you work in inner city, disadvantaged, let's say like East Vancouver sort of schools. Don't mean to stereotype them. That's not universal because that's already kids that are in high risk neighborhoods with relatively low incomes, lots of languages, and maybe a lot of other risk factors, okay? But I still think of it as universal. Selective is when we identify kids not because they themselves have problems, but because they're part of a class of people that have problems. So let's say we're going to do groups for kids who experienced a death in their family or a divorce. Or in America, we have Head Start. Head Start doesn't pick children because they're anything but in a class of children that are low income. Okay? There's nothing about themselves that's at risk. It's the class they belong to. Okay? We could say that maybe for First Nations people. Some people would think about them as a selective class. And indicated then is when they're beginning to see prodromal problems. So kids that are showing up in the principal's office because they're aggressive, disruptive, defiant of adult authority, getting trouble in the playground, et cetera, et cetera. But they're not diagnosable from a psychiatric standpoint necessarily, but they're a big problem. They're showing up in the principal's office all the time. They're the kids that everybody's spending all their time on. It's the 20% of kids that we spend 80% of our time on, Kim said last night. Then we identify cases and then we go through treatment, right? So prevention has these different components, but mostly we spend our money on the indicated, right? 80-90% of the money probably is the estimate. And I'll suggest that that's the wrong way to spend the money. So that's where the quote, the problem occurs. So the idea is we want to implement before the problem is fully developed, and that reduces the likelihood of later problems. So there's a wonderful man, his name was Jeffrey Rose, he's passed away now. He was a cardiac epidemiologist in England, and he wrote an incredible book that if any of you are interested in public health, you must read, called The Strategy of Preventive Medicine, and it sort of changed the field. And he has what he calls Rose's paradox of prevention, and that is a large number of people at small risk give rise to more cases of a disease than a small number of people at high risk. Okay, so now think about the indicated kids. They're the small group at high risk. Okay, now there's a paradox there. In addition, a preventive measure that brings large benefit to the community will offer little benefit to each person. So seatbelts is an example of that. You putting on your seatbelt conveys almost no reduction of risk to you, but it conveys reduction of risk to everybody, because if everybody's doing it, it reduces injury. But the chance that you're going to be injured is really small. So did anybody put on their seatbelts before it was illegal, before it was the law? Very few people did, right? And that's why, while seatbelts were put in because of Ralph Nader in the 60s and 70s, nobody used them. Hardly anybody used them, because no one saw that there was that much individual risk to themselves. And then, of course, the law was passed, and now you feel like you have to because you'll get a ticket. And now, pretty much, most people use them, right? The other paradox is an intervention that brings much benefit to an individual may have very small impact on a population. So we may take a child who has been highly aggressive, what we call my colleagues wrote a paper once called the $6 million family, which is about a family that cost Pennsylvania $6 million. And there's an enormous amount of resources going into that child and family. It's, we call it the black hole, where you just keep throwing in more resources, right? But even if there's a good outcome, it's a very little benefit to the population. Okay, now it is of benefit if it's aggression, because it could be less trauma to victims and et cetera. But the population doesn't benefit much from the treatment of one person. Okay, so I'm going to show you a video if this works. Oops. Let's go back. Should work. It's not working. Oh, because we transferred. Okay, don't worry about it. We'll skip it. Okay. I was going to show you a video which you can access on the web. If you go to put in prevention paradox, it's by David Hawkins, my colleague at the University of Washington, where he explains the prevention paradox visually. If you want to teach someone else the prevention paradox, you can use this video. Okay? But the first set of data really that showed this prevention paradox was data in cardiology. Of course, we're talking back to Jeffrey Rose. And this is an example. This is a very large study in Finland. It's published in 1998, so 20 years ago. And it looks at serum cholesterol levels and the risk of dying. So the deaths are these white boxes, okay? And higher cholesterol, right? Higher cholesterol leads to a greater risk of death, right? But more people die from mid levels of cholesterol than actually die from high levels of cholesterol, because why? This is a small class of people, okay? It's the prevention paradox, okay? Now you'd say, well, that's just about heart disease and it has nothing to do with education or anything else. But let's take lead levels. This is an estimate from a New England Journal of Medicine article, and the prevention paradox of the number of IQ points lost to lead levels. Well, we'd think, well, only if you had a really high lead level, right, would it affect your brain, your cognition, and subsequently your IQ. And what you can see is that this is the level at which there's real concern, lead levels of 5 or greater. And what you can see that the estimated IQ points lost in the American population is 3.1 million IQ points from the kids that have the highest lead level. But it's the kids in the medium lead levels that account for most of the IQ points lost because of lead. Because lead is on a continuum. And it's not just the, quote, indicated, they'd be the indicated kids, the kids in the red, that are affected. Everybody's affected. Even kids that have low lead levels, right, the lowest lead levels, lose more IQ points than the kids that are concerned because we have so much lead in their bloods. You see? So it's the prevention paradox again. So let's go to college drinking. I could go on for days with these. There's so many examples of this. Once you see it everywhere. This is the risk of harm in college students. This is a study at Harvard. Percentage of college students hurt or injured, that is going to emergency rooms because they're hurt and injured by the number of drinks they drank in the past 30 days. Okay? And you can see that the percentage of kids that are injured or harmed, this is the kids that drink 101 to 109 drinks in the past 30 days, the heaviest drinkers, right? Now, more of them are going to be harmed, percentage-wise, but they're a very small class. And most of the kids that show up in emergency rooms for injuries from drinking are not the heavy drinkers. In fact, they're the ones that don't drink much, and because their tolerance is low. Anybody here like that that's ended up having a problem? Or maybe you had 3 glasses of champagne when you should have had 2, right? Okay, so there it is in college drinking. How about school dropout? Okay, this is the analysis of 36 dropout studies. And even with multiple item prediction, that is if you knew about children's achievement and their behavior, only about 50% of dropouts can be accurately predicted. Okay? This means the largest percentage of students who are identified by dropout flags, as our dropout risk kids, do not drop out, and conversely, a large percentage of kids who do drop out in high schools are not identified. This is doing it at 9th grade. So only about 50% of kids who are going to drop out are accurately identified. So if I can illustrate this, think about screening, because that's what we want to do. We want to screen and then find the kids that are problematic, right? Isn't that what we want to do? Because we want to just use the resources for just the kids that need it, okay? And we're so good at all this. Okay? So let's say we screened all 9th graders for risk factors of dropout. Let's say both we knew their achievement scores, we knew their expulsion rates, we knew how often they were coming to school, et cetera. Okay? And let's say we identified 20% of the kids as high risk and 80% as low risk. Okay? That's usually what we do, something like that, 15%, 20%, whatever. Okay? And over time, 70% of the high-risk kids drop out and 25% of the low-risk kids drop out. Okay? So what happens? So 75% of the high-risk kids are 15 out of 20. 25% of the low-risk kids are 20 out of 80. So where are there more dropouts? There are more dropouts in the kids that weren't screened than in the screened kids. Okay? It's the prevention paradox again. So more than half of the students who drop out are in the low-risk group. Now, you could say that's just a problem that we don't screen well. But it's the same thing I showed you for cholesterol. It's the same thing I showed you for high-risk drinking. And we can go on and on. To the extent that our screening is better, this is going to be less the case. But it's always going to be the case as it turns out. Okay? So, to date in education and psychology, the full effects of these universal interventions are underappreciated. Because if we don't work with the entire population, there's no way in the long run we can reduce population health problems. Right? We can't do it just by working with the identified kids, because they're always going to be, even if we put all the resources into them, always less than half the people who are going to end up having the problem. Okay? Not the majority. We think about, well, if we just work with those kids, then we're going to really solve most of this problem of dropout, of behavior problems, or early arrest, early drug and alcohol binge drinking, whatever the problem is. So we underappreciate the effects of the universal interventions, because we think that just screening and working with kids that are already identified is somehow going to solve the public health problem, and there's no way that it can do that. Okay? So that's where social emotional learning comes in, because the process of SEL can foster a variety of educational approaches that promote these capacities, these mental well-being capacities, integrating affect and cognition and behavior. And there are lots of instructional approaches, right, to teach kids SEL skills, as you know. I've been involved really in more early childhood and middle childhood lesson work, but there are lots of ways to do this. Environmental conditions are really important, especially when we get to middle and high schools. Lots of ways to do this. But we do think that it's a conceptual framework that explicit SEL skills, especially for younger kids, but even for teenagers, are really important. Integrating into the academic curriculum areas is important, but that doesn't mean that you don't use special time for SEL development, okay? Teacher instructional practices are important, so the kind of pedagogy that teachers use is critical. But there are organizational and climate and culture strategies we want to think about at the school level. So we want to think about all these levels at once. And when we do that, you know the CASEL 5 areas I'll show you again later probably of competence. We want to improve kids' attitudes, and we've shown that that can happen, and we can enhance learning environment by making it more supportive and participatory and engaging for kids, especially as they move to secondary school. And when we do those things, we've pretty much shown that under high quality implementation, only under high quality implementation with evidence-based programs, that we can do all these things. Okay. Now, from a policy standpoint for education, this is the only one that matters, because these things don't really matter to schools as institutions. Okay? I use the analogy of the fire department, that a school has what I'd call the nature of school, what school's about, and that's about curriculum and instruction. And that's about STEM and language arts and math and reading, et cetera. And then there's what I call the fire department, and that's the school psychologists, counselors, social workers, special needs teachers. They're only there because there are kids that have problems, but they are not the center of the policy structure of education. Okay? And so for the last 25 years, as one of the founders of CASEL, our goal has been to move social emotional learning from the fire department to the curriculum department. Because that's where things happen, right? That doesn't mean to demean at all the fire department, but the fire department is there because problems occur, not because we're trying to improve the well-being of all children. Okay? So we have to think about where things are situated in understanding all this. Because in the end, the most important data so far, two sets of important data so far, are improved academic performance and benefit cost analysis. And I got into this because I was interested in conduct problems and emotional distress. And I done lots of randomized trials showing that you can reduce aggression and behavior problems and et cetera. You can reduce depressive symptoms in kids, but no one really cares about that in the policy world of education. It's just not on the radar of what's important. What's important is what? Even in British Columbia till now, maybe it's changing now, of course, because you have such an advanced set of policies. But what's important is the PISA scores, right? I mean, that's what it's about. Right? This is what the corporate world thinks about when they think about education, is academic outcomes. So we have these 5 skills that are the CASEL 5 skills, and there's a need for work on some of these now. You might be interested in some of the work of Camille Farrington and others in the Chicago work on sort of a model that's similar to this, but a little different for adolescents, that works more on plans and goals and mindsets. But whatever, we have these as the primary 5 components, and we want to have good SEL curriculum, and we want to have high quality instruction with good pedagogy. But we need school-wide practices and policies. And just having teachers doing this alone in the classroom is not going to get to the point where we have what we call healthy relational schools that really have a public health influence. Okay? Because it's not just about the kids anyway, it's about the teachers and about the people that work in the lunchroom and the custodian. It's about everybody being in a healthy work environment. And then we want to think about family and community partnerships, which is the hardest part of this. The school-wide is really solvable with leadership, with good leadership in schools. The community and family partnerships are things that people put on the outer rim, but they don't really know what to do. I think it's still a hard nut to crack. So what does it mean to then be systemic? It means that we have to really think through what we're doing, because usually what happens in SEL is a school district, Coquitlam, Roberts Creek, Maple Valley, whatever, they have a superintendent or an administrator that gets excited and allocates some money for a while, or they get a grant from the Ministry of Education, and There's no real planning oftentimes, although that's not true in Coquitlam, it's not true in Roberts Creek, because those are places that really have thought about this, but I'm just using examples. And usually what happens is teachers are told to show up to a workshop, and when they get there, they think, why am I here? Who said this was important? Why do I need to learn this? I already know what I'm doing in my classroom, and I'm really busy, and why do I have to waste my time on these professional development days? I mean, that's what most people really feel when they walk in the door. So being an SEL trainer for 35 years, that's the feeling I get oftentimes when I start a workshop in a new school, because no one really has made an engaged plan. There's no real vision. People haven't had a work group to think ahead about what they are doing or why they're doing it. And so at the beginning, actually sometimes the very best teachers, the teachers turn out to be the exemplar teachers in this kind of work, are the most resistant, right? Because they already know what they're doing, and all we're helping them do is to create a systemic developmental model of what they're already doing. And they think they already know what they're doing, and they're great teachers. The great teachers do know what they're doing. But adding a developmental process that's clear, once they see it, actually helps them, okay? So getting this vision is really important. Assessing your resources and needs is really important. I mean, I've been in schools where we're doing an SEL curriculum and there are 8 other interventions that are completely fragmented and have no relationship to each other, right? It's common. It's really commonly the case. There has to be embedded professional development, and that means, like we always say, that the first training should never be the last training. You have to think about ongoing training. It's not a matter of like having a 2-day workshop before school and then it's all done. It has to be a progression over time of training and coaching. And then, of course, we want people to implement evidence-based programs and practices. And that's great when they exist, and they exist a lot of places now. That is, for most issues, we have good evidence-based programs. It's not so true in high schools yet, for example. And we want to integrate school-wide. We want to think about everybody. We want to think about the bus drivers, right? And the school secretary, most important person in the school, right? The custodian to some kids is the most important adult in the school, and usually, oftentimes, the only important man in the school, right? So we want everybody to be involved. We want everybody to learn these skills. We want everyone to know that they need to model and practice these skills just like the kids do. And then, of course, we want to use data to continually improve, because at the beginning, it never works that well. Any new curriculum, look at the school transformation research. These giant school transformations that have been done in Canada and in the United States, they almost always fail. And they fail because they put an enormous amount of resources in the first year or so, and then it's sort of, they step back. And what happens is you've got to have continuous total quality improvement to figure out that it's not going to work well the first time. It's going to work sort of okay, and you've got to figure out how to contextualize it over time. Okay, so you probably have seen something like this before, the sort of the pyramid that's used by people in PBIS, for example. PBIS is a great idea, but it's it's sort of a brain fart to me, because no one would argue with the idea that, 1, we should have good rules in schools, and 2, that we should monitor where problems occur. And that's mostly what PBIS does. Who would argue with that? But it isn't teaching children the social emotional competencies that are necessary in addition. It's more management, right? So in the universal is really big here, because it should be. This is where we should be putting a lot of our resources, because as I explained to you from the prevention paradox, the only way to improve public health in our society is to put up sufficient resources here. And then we have the indicated, where we call now an education tier 2. Did you use that term in Canada? And then tier 3, and oftentimes the distinction between these two is completely muddled. If I talk to 3 different people that are in the PBIS world, they tell me different definitions of tier 2 versus tier 3. All it means is that now the kids are a pain in the butt to somebody. And so systemically, they're getting kicked into a screening process which may or may not help them. Okay. So I told you, Kim told you I was one of the founders of CASEL, and so we want to think about the models of all this. What is it we want to need to do in the long run? And this is sort of a broad model that CASEL developed. We want to think about this in district-wide ways, school-wide, but also district-wide. We want to cultivate commitment and support for SEL at the district levels. So this is complicated, especially in the United States. I don't know how much change you have in superintendents here, but for example, CASEL adopted 7 large districts in the United States: Anchorage, Austin, Nashville, Oakland, Sacramento, Chicago, and Cleveland. And in the first year and a half, every superintendent changed. And then in the next year and a half, 4 more of them changed a second time. Okay? So what does it mean to cultivate this? It means that the superintendent, who is the face of the district to the community, is going to probably be rotating all the time. So getting a lot of input and educating the superintendents is probably not the sufficient way to do this. It's got to be the next levels down of people who are probably going to be more stably in the district, have probably worked up from teacher to principal to curriculum directors, et cetera, people that are part of the real structure of the district. Okay? We need to assess SEL resources and needs, because a lot of times money is being spent, a lot of money is being spent, but it's not being spent strategically. We want to establish programming, and we want to have continuous systems of improvement. Very few districts have all this in place. Okay? Think about it as an intention that we want to have. It's a goal that we want to have. It's hard to get all these in place at once. It takes a lot of commitment from senior administrators. Even great principals that are very committed to SEL often have a hard time getting all this in place. Maybe it takes them at least a couple years, and they need coaching and support to do it. Okay? And when we do this, we see these kind of short-term outcomes of better connectedness of kids, and teens a better sense of purpose, the kind of outcomes I've already talked about. But we're interested in these long-term outcomes, and these are really important. We want to think about a public health model. We're thinking about college and career readiness. We're thinking about how to carry on healthy adult relationships. Many of you must know the 4 R's curriculum from Toronto, a fantastic middle high school curriculum, which is really started out about casual rape in a way in high schools, but now is brought into a real curriculum about how to carry on adolescent relationships. What does it mean to have a good relationship, especially a sexual relationship? And that kind of work is really important, because this is the basis of adult relationships, and many people become impaired because of the relationships they have in adolescence. And of course, we want to be thinking about positive mental health and engaged citizenship. And I won't go on about this, but we have this long-term study called Fast Track, which I maybe come back to in the second part of my talk. It involved interventions for 9 years with very, very high-risk kids, the most high-risk kids you could imagine, but also universal interventions. So the whole school's adopted an SEL program, and then these kids got many things in addition. And it's a large randomized trial of children in Nashville, Seattle, Durham, North Carolina, and 3 small economically impaired towns in Pennsylvania. And one of the outcomes that was just published at age 25 is the kids in the intervention vote more. They have higher voting rates from this work, because they became more connected to social institutions. Okay? So engaged citizenship in one way in a democracy is probably our most important outcome, right? And especially as you can see what's going on in the United States right now, engaged citizenship is a critical issue that I think has lapsed. So given all this, that we want to have systemic SEL, and I'm ending, so Stephen and Marna can speak. We want to integrate, and that's the big problem we face now. We face two kinds of integration problems. And I've been working on these for years, but I don't feel like I've gotten very far. I think they're really, really big challenges. The first is across the ecologies of a school. How do we work across the school, the classroom, the school, the family, and the neighborhood? Right? It's still not well solved. We don't have good models of the neighborhood aspects of this. We have some models of family participation, but not very good, I don't think. And we have some good examples now of school models, but most schools don't think and work in this integrated way. They need a great relational leader to do so. Okay? Where do these great relational leaders come from? Well, there's no great relational leader principal institute training in the United States or Canada, right? So where are they going to learn these skills? How are they going to find the mentors and the models of other great principals that show them the way to do this, unless they just develop it themselves, which most of us don't just develop things ourselves. We have mentors that we learn that give us models of how to do things well. And then lastly, we have the levels of service. So I talked about universal, which often includes both promotion of well-being and the prevention of problems. I don't separate these two, because usually you prevent things by promoting skills. And then we have selected and indicated in treatment. And this issue of the mental health world, the child psychiatry and social work world, and the universal world often speak different languages, and they don't communicate very well with each other. So I'm in schools in which we're teaching kids to do things in SEL programs, and then they do them in treatment or in small groups, and the therapists have no idea what they're doing, and these are the skills that are going to help them. Okay? I've done workshops with social agencies like child mental health agencies and schools together, and the first question I ask them is, who's invited to the Christmas party in the building, right? If you're a mental health person or you're an outside social worker from a family services agency, do they invite you to the Christmas party? Do you park in the visitors part of the parking lot, or do you park in the teachers part of the parking lot? Right? It's these kinds of things that make a difference. Are they really part of the ethic of the building? Do the mental health people hang around in a teacher's room and get to know people? Or do they just come in, pull a kid out, do whatever work, and then they're out of there, right? This issue of integration, what does it mean to have a healthy school? It means that we're really going to integrate these tiers, if you will, if you want to call them that, together. And this is a really big issue. It happens not only at the level of the school, it happens at the level of the community, and it happens at the level of ministries. I mean, it's not the ministry's problem. It's everybody's problem, but you can see it the same way. That's why Stephen's great. I'm so happy that his department is actually in the Ministry of Health, because thinking about how these cross ministries is critically important to solving this problem of integration. Right?